is everybody? All right. Amazing. You know, it's amazing is that I was on the physiology committee for like 5 years, writing the national boards. And so you would think that you want to get sort of sidetracked and it's on physiology, but apparently not. So, what's that? Are you still? No, they cycle you off after 5 years. You've got to take a break for it. They want, you know, fresh ideas or whatever, fresh blood. So.
That's what they told you.
So anyway, welcome back. Hope you had a good summer. All right, so we're going to start with, by the way, to stop me at any point, I'm going to go fairly quickly with this. I'm not teaching physiology, I'm just trying to review stuff, catch you up, get you back on track, okay? So we're going to start with transcription and translation. So what does it mean, transcription, Rebecca?
For DNA to be copied to RNA.
You want to write down the code, right? Okay, you're transcribing the code onto what? What kind? Messenger RNA. Yeah, writing the message on messenger RNA. Okay, so you're putting the message, the code on messenger RNA. And so, which strand are you using for that, Isabella Grace? By the way, your hair looks awesome.
The leading sense.
Well, there's either a coding strand or a
Coding.
template strand.
Template, yeah.
It's the template strand. So anytime you're going to make multiple copies of something, think of what would you use a template for? You use it to make the same exact copy. So let's say you wanted to do a shape like a kidney bean on your wall. So you make a template, you spray it, then you move it over, you spray it. So you're making lots of copies. So how do you make a copy of the code? You're using the template strand. That's how you remember that, okay? The codons are on the coding, are on the messenger RNA. You put the code on the messenger RNA, right? So obviously the anticodons are going to be on what brand? The tRNA, okay? So you separate the DNA, you use the template strand, which is here, RNA polymerase is the enzyme that's going to start the procedure of making the messenger RNA. Where is this happening? Where in the cell? Dana? Where in the cell is this happening? In the nucleus, okay? Remember, the DNA is locked away in the nucleus to protect it, right? So we're going into this is happening in the nucleus, and then the messenger RNA has to leave the nucleus. How does it do that, Luke? What's the little doorway to get out of the nucleus? Where is it going?
It's going to the cytosol.
What organelle? What's this?
It's looking for ribosome.
What's that?
Ribosomes.
Yeah, rough ER.
Rough ER,
Okay, so
yeah.
it's going to the ribosome on the rough ER. And it's getting out of the nucleus through the nuclear pore. Okay, that's a little doorway. So now that you've made the messenger RNA, it's going to look very similar to the coding strand, except what's going to be the difference, Cam?
Can you say that one more time? I'm trying to get
What's the difference between the coding strand and the messenger RNA?
backwards.
Look here.
That means
Right, you're going to replace thymine with uracil. Okay, that's the only difference. Okay, so here, this little worm here is the messenger RNA. It leaves the nucleus through the what, Luke?
Nuclear pore.
Very good. And then it goes to the ribosome. Here's your ribosome, this little kidney bean thingy here. Okay, and the transfer RNA is going to bring the first amino acid. Rami, what's the first amino acid? Methionine is correct. Very good. So it's going to bring methionine, okay, and attach here. Once you bring the next amino acid in, it's going to create a peptide bond right here, and that releases this transfer RNA to go get another amino acid. Alyssa, what's the amino acid this first one's going to go get? has to be methionine, otherwise the code is totally gonna be wrong, right? So it's, the anticodon here is gonna fit the code for methionine, right? So it has to go pick up methionine. Anyone have any questions on that? Okay. So, and then you just keep forming these peptide bonds until you get a polypeptide and it eventually becomes a protein. And where is that gonna go to get further modified? Is that Matt up there? No, that's Eric. I just see like a chin with a beard, so it's Eric. Yeah, where is this polypeptide or protein gonna go next? After it's in the rough ER, where's it gonna go to get further modification? So let's say you wanna put a lipid on there, or you wanna put a carbohydrate on there, or you want to associate several polypeptide chains together to create something. Where's that gonna happen? Golgi. It's gonna go to Golgi for that, okay? Any questions on that? All right. So whenever you get this question, what should you do? Draw a circle, that's the cell, and then wherever it's more hypertonic, if it's in a hypotonic solution, where is it gonna be more hypotonic? Hypertonic. Inside the cell, you put a plus sign next to inside the cell, and then you put an arrow going to the plus sign. So what's gonna happen to that cell that's in a hypotonic solution? Swell and burst, okay? So as long as you do that, if you draw a circle, and if it's hypertonic solution, you put the plus in the solution. If it's a hypotonic solution, you put the plus inside the cell, draw an arrow towards the plus sign, and then you know what's gonna happen. If it's going out of the cell's gonna crenate. If it's going into the cell is gonna swell and burst, okay? So you're allowed to draw little pictures and stuff on the test, so do whatever you gotta do. Mitosis. So what's the definition of mitosis? David? Not technically not, right? Canero, por favor. Anyone? Mike? It's the division of the nuclear material. So make sure you know that, okay? Because we talk about mitosis as a division of cells, right? You say, all right, there's one cell that's going to divide and make two daughter cells. But technically speaking, it's the division of the nuclear material. So what part of the cell life cycle is not part of mitosis? So remember, well, maybe not, but cell life cycle is if not. Which part of it is not mitosis? Interphase. Okay, so G0 is the first phase in interphase. Christina, do you remember what that is? The cell is sitting there, filing its nails, watching TV, spitting the nail across the room, right? It's just doing what it does. It's not getting ready for anything. G1, what happens? What happens in G1? Starts to get bigger. Very good. Who said that? Very good. It starts to get bigger. It starts to replicate the organelles. And then you go to the what phase? The S phase. What do you need for the S phase? What nutrients? B12 and folic acid. If you have a deficiency in those, what do you wind up with? Big cells, megaloblasts, right? That's why you get megaloblastic anemia, right? So if you don't have B12 and folic acid, you wind up with larger than normal cells. And then G2, you finish making whatever proteins you need and organelles, and then you go into prophase. Okay, prophase, you're going to see the appearance of the mitotic spindles. So centrioles migrate to opposite poles, set up the mitotic spindle. Mitotic spindle is made from what? Who remembers? Kelly, remember? I'm sorry, Kate. What are mitotic spindles made of? What part of the cytoskeleton? Microtubules. Okay? Is that what you're gonna say? Okay, good. All right, so they're called they're made from the microtubules. So in the early prophase, you see the centrioles migrating, setting up the mitotic spindle, and then the chromosomes are going to attach to the spindle. In metaphase, it lines up in the middle. Metaphase, middle. Anaphase, they pull apart. They start to migrate to opposite poles. Telophase, so what I forgot to mention, the first thing, since mitosis is what? What is it technically, Panero? Division of the nuclear material. What's the first thing you got to do if you're going to divide the material in the nucleus? You have to get rid of the nuclear membrane or the nuclear envelope. Okay, so that's what happens in prophase. And what's going to be the last thing that you're going to do? Reform the nuclear membrane. So in telophase, you're reforming the nuclear membrane, and then cytokinesis is the actual splitting of the cells into two daughter cells. Any questions on that? So just remember hip and mat, and remember the first one is not part of mitosis. All right, and cytokinesis is really not part of mitosis either. That's when the cytoplasm of the two cell splits. All right, loose connective tissue, also known as, what's the other name? Josh? Areolar. You see the word areolar? You think of what's around the nipple, right? Like areola. Okay, areolar is loose connective tissue. It's just another name for it. Okay? In loose connective tissue, you have, well, it's connective tissue, so therefore there are three things. What are those three things, Cam?
Ace.
ACE, that's right. A stands for amorphous ground substance. Okay. C stands for, Jillian? C for cells. And E, extracellular fibers. Okay. You have three types of fibers in loose connective tissue. What are they? Luke?
Intermediate filament?
That's cytoskeleton. Come on, what is everything made of? What's the 2x4 of the body? Collagen, okay? And then you have stretch and recoil, what are those? Elastic fibers, and then you have reticular fibers, which are actually made from type 3 collagen. Okay? So those are the extracellular fibers. Going back to the amorphous ground substance, that's what fills in all this space. And what are they? What's the acronym that we use for that? Rami? Gags. Wow. Remind me that we have you in charades. Gags. What does that stand for? Isabella? Glycosaminoglycans. What is it basically? Is it a fat, Mike? It's sugars. It's a bunch of sugars put together, and it's sort of like a sponge. Think of it as a sponge. What it does is it holds lots and lots of water because it's charged. So it holds lots and lots of water. Okay, why do you want lots of water? Brandon? Diffusion. That's what this tissue is for. So I have a blood vessel here, and Luke is a cell over there, and I leak out of the capillaries, and I have to do what to get to him? Diffuse through the loose connective tissue to get to that cell. Okay? Any questions on that? All right. So, and then let's go to cells. So we have fixed cells. What does that mean? Rebecca, what does that mean? They don't move, or their populations are relatively stable. Okay? Doesn't mean that they can't move around, but they're just always there, and they're always there in sort of, hola, ¿qué tal?
¿Cómo estás?
¿Todo bien? ¿Y tú?
Great.
Estaba en Colombia.
Sí, I just got back.
Ah,
4 hours ago.
I bet it was great.
Oh.
Bienvenida. You guys know Myra? No?
No, what's up?
Well, you should know Myra. Anyway, do you know Christina? Do you know Christina? You
Yeah,
know
I met
Myra?
Christina.
Hi. All right, so, fixed cells, their population in loose connective tissue is relatively stable. Okay, so what makes the fibers and the gags? Fibroblasts, very good. Okay, so fibroblasts make the fibers, so they basically make what they're in. Okay, so they're gonna be fixed, they're gonna be there. Now you do have fibroblasts that are somewhere on the spectrum between fibroblasts and smooth muscle cells, and they're called myofibroblasts. Why do you think they're called myofibroblasts? What can they do? Contract. Why would you want to contract in the connective tissue? What would it do? You contract, you're stiffer. It stiffens the tissue. Why would you want to stiffen the tissue? To increase the load that it can actually hold. Does that make sense? Okay, so if you have very stiff thoracolumbar fascia, okay, how is that going to affect how much weight you can hold over your head? It's going to be much better than if you have loose thoracolumbar fascia. Right now, if you're in Cirque du Soleil, you don't need stiff thoracolumbar fascia, right? You want to put your butt all the way onto your head, then you need to have a little bit looser situation, right? Okay, so anyway, so we have fibroblasts are fixed, okay? We have tissue macrophages which are fixed. Depending on the tissue, they're gonna have different names. In the liver, what is a tissue macrophage called? Okay, what's it called? Kupffer cell, very good. Katie, you're up again. What's it called in the lungs? What's the very end structure, the little sac at the end of the lungs called? Alveoli. So they're called alveolar macrophages, or also known as dust cells. In the skin, they're called histiocytes. In the central nervous system, Melissa, what are they called? What are they called? Microglia. Okay, microglia. Those are the phagocytes in the central nervous system, Robbie.
Is there a different name for a skin?
Histiocytes.
Yeah, I'm saying, is there a different name?
Langerhans cells? Okay, yeah. Okay. All right, so depending on the tissue, they're gonna have different names, right? But they're always there. And what are they, what's their purpose? What's the purpose, Christina? It's in the loose connective tissue, right? It's on that guard tower. Where are most of your infections gonna come from? The last 20 times you were sick, Luke, what was it?
I've never been sick a day in my life.
You're full of shit. Last 20 times you were sick, it was either gut, probably gut a lot more. Most of us get gut infections, you know,
Respiratory
3 or 4
infections.
times a year. And then you get a respiratory infection once or twice, you know, maybe once every 2 years, right? So why? Why is that where you get your infections? How thick is the mucosa there? 1 cell. What's right underneath that 1 cell?
Basement membrane. Is it basement membrane?
There's a basement membrane, but what's beneath that? The lamina who said that? Very good. Lamina propria is the loose connective tissue just beneath the epithelial cells in the mucous membranes, okay? That's where most of our infections are gonna happen. So that's why you want macrophages there. So as soon as something comes in, you attack it and hopefully kill it before it colonizes. The reason why we don't get sick all the time is because we have this surveillance that's happening all the time that's killing things before they actually are able to colonize us. When we get sick is when they colonize us and they start rapidly producing and then they start causing symptoms. Okay, but we are ingesting and inhaling all kinds of pathogens every day. And what happens when they get in? The macrophages there to kill them. They also do something to induce the acquired immunity. What is that, Dana? So they're part of the natural immunity. Equal opportunity killer. They recognize what are called PAMPs, pathogen-associated molecular patterns, usually carbohydrates on the surface of bacteria is an example of that. Something that's a pattern, they can recognize that and they go, that's not us, let's go kill it, right? So they kill anything, right? But they will induce specific immunity or acquired immunity. How do they do that? That's not vaccination. What do macrophages do? So here is Rebecca is E. coli. She gets it, and here I am. Thinking something better, salmonella. Or your infestants, right? The black plague. So she comes in, right here. I am a macrophage in the loose connective tissue. I grab her and I rip her apart. What do I do with her? I just killed her. What else do I want to do? Antigen presentation. So now I'll take pieces of her and put it on the surface with what? MHC, okay? MHC1, MHC2. That is antigen presentation. Why do we need that? Isabella?
So that then we can, say it again? Yes, the T cells are.
T cells can recognize it and then T cells get activated. They activate B cells become plasma cells, and then you get lots and lots of what, David? Antibodies, that's right. So that's part of your specific immunity. So macrophages have a foot in natural immunity, but they also induce acquired immunity or, specific immunity.
MHC1 versus
You should know that MHC1 is on all body cells except what? Red blood cells. MHC2, in addition to MHC1, MHC2 is also going to be on cells that are part of the immune system. Things like mast cells and all the white blood cells that have MHC2. Okay. Remember, HLA is another name for MHC, right? Human leukocyte antigen. The reason why it's called leukocyte antigen, where it was first discovered on white blood cells. Okay? And remember, type 2 is going to be the D group, DR, DQ, DP. Yes? HLA-A, HLA-B, and HLA-C are type 1. Okay? Let me say that again. Okay, MHC1 is HLA-A, B, and C. MHC2 is HLA, DR, DQ, and DP. Okay? And those are going to be only on immune competent cells. So immune competent cells have MHC1 and MHC2. All the other body cells. So how does a cell in the lining of the an epithelial cell in the lining of the lungs, how does that tell the immune system, I've been attacked? Because it has MHC1. Okay, and that can activate cytotoxic T cells and kill that cell. So the cell can't become a factory for virus or bacteria to grow it and replicate. Okay? Eric?
where do interleukins play a part? Like,
interleukins are just chemical signals that will, like interleukin 4 and 5 is what's released from an activated T lymphocyte, and that's going to cause a B cell to turn into a plasma cell and start making antibodies. So basically, interleukin, what it means is in between two white, he's a white blood cell, I'm a white blood cell, right? How do I communicate with him? Interleukins. So I make this chemical signal. He has something that's going to receptor that's going to pick that up, and then that's going to tell him to do something. Okay? The broader term is a cytokine, right? Chemicals made by cells, right? All right. We also have mast cells, which are fixed in loose connective tissue. What's the purpose of a mast cell? Genero. First of all, if I pull the mast cell out of you and we looked in it, it would have little granules. Where do those granules come from? What cell organelle makes those packages things up? Golgi. Very good. So what are we going to find in a mast cell? Histamine, chemotactic factors, and heparin, anti-clotting, anticoagulant. So the histamine, what's the target tissue? What's target tissue, Christina? Histamine. What does it cause? Right. How does it cause inflammation? What's the target tissue? Blood vessels. Okay, so it's going to attach to histamine receptors on the blood vessels. What are the blood vessels going to do? They're going to vasodilate. What's going to happen to the pores in the capillary? They're going to open up even more and become leakier. So now the fluid in the cardiovascular system starts to leak out into the loose connective tissue. And that's why you get swelling. In an anaphylactic reaction, you get a massive release of histamine. Okay, we'll talk about that later. Any questions on that? Adipocytes are there also. They're just fat cells. Melanocytes. Okay. Then we have the wandering cells, which means that they may be there already, but their numbers will greatly increase when there's an infection. So when you think of an infection, what do you think of? What cells? WBCs. So the only WBC that's a fixed cell is a macrophage. Okay. All the other ones are wandering cells. Okay. So their numbers will greatly increase when there's an infection happening. Okay. When would you see what kind of infection, Myra, will cause the eosinophils to go way up? Allergies and parasites. Okay. So depending on which kind of infection, bacteria, generally, you're gonna get a lot of neutrophils. Don't forget, neutrophils are always the first ones on the scene, right? They're the most numerous of the white blood cells. We'll get into the blood in a few minutes, okay? So, dense, irregular connective tissue. Now, this really isn't a misnomer in that it says it's irregular, but this is what you're gonna be testing on, so don't worry about that. But remember, when we talk about fascia, the sheets of collagen, the collagen fibers are very regular in each sheet. It's just they're superimposed like this. So when you look at it, it looks kind of haphazard. But if you look at each sheet, it's this one's going this way, this one's going this way. Okay? So capsule of visceral organs, periostea, perichondria, nerve, and muscle sheaths, dermis. Basically, fascia. Okay? What it does is it's going to resist forces from applied directions, help prevent overexpansion of organs. And you see that the collagen fibers are a little bit less regularly set up, but that's not really true. This is not Polina science, but we'll just go with the old shit. Okay? I know, Josh, I'm making you crazy already, right? Okay, then we have dense, regular connective tissue. Very simply, tendons and ligaments. Okay, the collagen is much more regular. By the way, what's going to be the predominant cell in this? What do you think? Lots of collagen, so. Fibroblast, very good. And in this, you're gonna have lots of fibroblasts. A resting fibroblast is called a fibrocyte. If it's not active, sometimes it's called a fibrocyte. All right? And you know that tendons connect muscle to bone and ligaments connect bone to bone. All right? Big difference between the two is that ligaments, because they have to resist force in multiple directions, are going to have collagen that's not quite as regular. So in a muscle, in a tendon coming off a muscle, they're all going to be going in the same direction. But if you look at the ligament, the collagen fibers are going in different directions because it has to resist in different directions. Also, they're going to be a lot more elastic fibers in ligaments because they need to stretch and then recoil. Okay, but you don't want that to happen. You know, you go to pick up a weight, you don't want your tendon to go, you know, stretch first, right? You want it to be pretty stiff. But a ligament, you know, you're moving your ankles around like this, you want it to be able to stretch and recoil. Okay. Adipose is specialized connective tissue. What are the hormones that are produced in adipose tissue? Right? Stuff that just turned your hair color a little darker. It was so bright with the knowledge was coming out, and then it just went down just a little bit. Yeah. I'll give you a hint. It tells you to stop eating. Somebody said it. Leptin. Okay, so it produces leptin. It also produces resistin, which makes you resistant to insulin. It also produces inflammatory chemicals that are implicated in things like heart disease and diabetes and cancer. Okay? It also will produce about 20% of your angiotensinogen. Most of it's produced where? When in doubt?
Liver.
The liver. Okay, very good. Okay, so 80% of it's in the liver. About 20% of angiotensinogen is made in the adipose tissue. And we'll talk about that angiotensin pathway later. Okay? Reticular tissue, remember I said that the reticular fibers are made of type 3 collagen. This is more like a mesh that holds the cells together. You see this in the liver, kidney, spleen, lymph nodes, bone marrow. You see how the cells are attached to this? Kind of it's almost like the net bags that onions come in. And imagine that with little cells attached to it. Okay? All right. Cartilage. So cartilage is a connective tissue, therefore it has to have 3 things. Jillian, what are those 3 things? ACE, good. It has to have amorphous ground substance. What's it going to be very high in? What are the 2 gags? Well, the 3, but polyuronic, chondroitin 4, and chondroitin 6 sulfate. Very good. Okay. Why do you need so many gags in cartilage? Brandon? Why? That's right. Because it's avascular. Okay. The only 2 tissues that I'm aware of that are avascular are cartilage and epithelial tissue. Okay? Everything else has blood. All right, so you look confused there.
No.
No?
The epithelial tissue threw me off a little bit.
Epithelium is the lining.
Yeah.
You know, that.
It makes sense.
Yeah, okay. All right, so the way it undergoes growth, it can go interstitial growth within the cartilage. So it's like in the middle of the cartilage. So imagine we're taking this cell and we're looking at it up here. So what's going to happen is, by the way, what
Telophase.
cell phase is this in?
Telophase? That looks like a cleavage furrow.
They're pulling apart, so it's anaphase. All right,
We'll debate that later.
what's that?
I'll say, we'll debate that later.
What? Do you actually see a, nuclear membrane reforming here?
I see the
think
cleavage
not.
furrow, so.
No, you better put in another set of contacts. No, I think this is, anaphylaxis, because they're pulling apart, but maybe. Anyway, so, it divides within the, cartilage matrix here. This is gonna be type 2 collagen. Type 2 collagen resists pressure. Okay, think about what does cartilage do? It has lots of water in it, so it's really good for cushioning, right, and pressure, resisting pressure, okay? So interstitial growth is within the tissue, and then appositional growth is on the edge. So here's your perichondrium. Perichondrium is gonna be two basic areas. You're gonna have the fibrous area, which is gonna be mostly fibroblasts, and then those fibroblasts migrate towards the cambium layer, which would be a layer of dividing cells that are going to become eventually chondroblasts and then chondrocytes. Any questions on that? All right. Three types of cartilage. Hyaline cartilage is going to be the major cartilage in the body. It's on all your joints. It's going to be in the larynx, trachea, the bronchi, the nose. This is going to be mostly, you're going to have lots of gags, and you see the chondrocytes here. And these are the more mature ones when they become round, by the way, right? Elastic cartilage, you have the 3 E's. External ear, eustachian tube, and the epiglottis. You also have the cuneiform cartilage of the larynx, if you want to memorize that. But if you just know the 3 E's, I think you're okay. The big difference in this is it's gonna look a lot like hyaline, except it's gonna have elastic fibers in it as well. Fibrous cartilage, it's gonna be in the menisci, and also in the intervertebral disc. It's gonna be in the annulus fibrosus. Think of the word annulus. It's like annual rings of a tree, and fibrosis is made of fibrous cartilage. This is considered a transition tissue between dense, regular connective tissue like a ligament or a tendon and cartilage. Okay. Okay, this is the only one. This is not covered with perichondrium. These two have perichondrium, except for this hyaline, not at the joint. Okay. Any questions on that? All right, bone. Epiphysis, metamorphosis joins the diaphysis. The epiphysis is the end. In flat bones, you have diploe, which is the trabecular bone, and then you have the cortical bone here. Diploe is where in an adult you're going to have the red bone marrow, active red bone marrow. If you look at the fibrous layer on the outside, this is periosteum. You're going to have 2 layers again. You're going to have a fibrous layer and a cellular layer. That cellular layer, where's it coming from? It's coming from the fibroblasts that are in the fibrous layer. Fibroblasts migrate to that cellular layer, and then they become osteogenic cells or osteoprogenitor cells. They're going to become osteoblasts. What does that mean? It's blasting out the bone, the bony matrix. The matrix is made up of type 1 collagen and very little gags, a little bit of hyaluronate, but it's, remember, dry as a bone. So it's going to have very little gags, okay? But there are some gags, and you have type 1 collagen, and of course you have cells. And then once it becomes fully mature, it's called the osteocyte, and that's where it's calcified, and it's in that lacuna. It has those filopodia that reach out to the next cell, and that's how it gets its nutrients, okay? And then the inner part here is called the endosteum. This is a less complete connective tissue over the bone. And the inner part of the bone, you're gonna have these large osteoclasts. Where do they derive from? Do you remember? What's that? This is a tissue macrophage. Okay, so remember we were talking about histiocytes, Langerhans cells, Kupffer cells, alveolar macrophages, dust cells. This is your microglia. This is your tissue macrophage of bone. What's the job of it though, Myra? Is it to engulf in foreign bodies and, kill them and all these pathogens?
It's,
Say no.
It's going to break down.
It's gonna break down so you can resorb bone. Why do I break down bone, Eric? Yeah, why do we want to break down our bones? Why don't we just make the bone and it's like, okay, cool, it's made.
Later on, stronger.
Well, you may need to stronger bone, right? So let's say Isabella, comes in the semester, she looks like this, and by the end of the semester, she looks like Maria Sakkari. She's doing that Spartan workout, she's pumped up. And what's gonna happen is if her muscles get too big and too strong, she's gonna have an avulsion fracture, right? She'll go like, hi, about these. Oh, God, just rip right out of the bone. So the bone has to hypertrophy. You have to remodel the bone depending on what the load is that you're asking the bone to do. So we're constantly remodeling our tissues, right? The digestive tract every 2 to 3 days, you're completely redoing the lining of your digestive tract every 2 to 3 days. Takes about 3 years to turn over trabecular bone, and it's something like 12 years or something like that to do the cortical bone. So that takes a lot longer. But you are constantly remodeling your bone. And that's osteoclasts break the bone down, osteoblasts build it up again.
3 years for what?
Trabecular bone. Every 3 years, you completely redo your trabecular bone. Okay?
So you
All right. So the cells, the only one that's not derived from these osteoprogenitor cells, where's this? Right here. The only one that's not derived from the osteoprogenitor cells is the osteoclast. What is it derived from? Once again, Katie? Macrophage, very good. It's actually, we see there's multiple nuclei. It's a whole bunch of macrophages get together and fuse to make one big giant cell. And what do you think it's using to break those down? I mean, what do you think it's using to break the bone down? What organelle? Say, really put that head on it, like chop it. Wrong. Chop the head off. Lysosomes, that's right. So it's using the hydrolases in the lysosomes to break the bone down. Okay? What stimulates osteoclasts? Rankle, very good. And that's produced by what? Remember. Parathyroid hormone stimulates a cell to make rankle. What's the cell? Osteoblast, very good. Okay, so remember, it's a roundabout. So what are osteoblasts usually doing? They're usually
building.
making bone. But when it gets a signal from the parathyroid gland, it stops making bone and starts making rankle. And then the rankle stimulates the osteoclasts to break the bone down. Okay, so it stops doing, I'm making bone, and then all of a sudden parathyroid's like, oh, come over, and then it comes over here. Okay, I'm gonna make rankle instead. Okay? Any questions on that? All right, so you have the osteocytes, mature bone, you see the filopodia here. They call it canaliculi. It's not really, canaliculi are the canals that the filopodia are in. Okay, so if you imagine if I was put into a plaster cast, okay, and then dissolve my body, okay, the lacuna would be where my trunk and head are, and the canaliculi would be where my arms were and my legs were. My arms and legs are the filopodia. That sounds great, right? Let's dissolve Dr.
I was like, what a morbid analogy.
Well, I think it's good.
It works though.
All right, and then we have the osteoblast. Remember, what is this system, the Haversian system, called? What's the other name for it? This is very confusing, these two terms. There's osteon and osteoid. Osteon is the Haversian system, where you have the Haversian canal, the Volkmann's canals, right? Okay. That's called osteon. Osteoid is the type 2 collagen, type 1 collagen and the gags that the osteoblasts make. So it's the organic matrix of the bone.
The bone get nutrients through the canaliculi or through?
Well, through the filopodia, the osteocytes do. So if I'm frozen in in calcium, right? Hydroxyapatite, right? How am I going to communicate with him? Like this, right? So Isabella's a blood vessel giving him nutrients, and he goes through him, connects to me, and then she's even deeper in the bone. So we're all communicating with each other through these filopodia. Yeah, I have scars all over. Yeah, this one.
Oh, I put an IV in that vein, right, Josh? Right?
Well, this is a big lump of bone right here. I fell between first and second semester, broke both my wrists and my jaw at the same time. Yeah, that's what that's all from. Yeah, hideous, right? Like Frankenstein. Dr. Frankenstein. All right, so anyway, any questions on this? All right, composition of bone. The organic portion is very small. It's only about 33%. It's mostly collagen, type 1. The majority of it is calcium, about 40%. And then you have carbonate and phosphate. So the calcium phosphate are the major components. You have a little bit of magnesium, sodium. That's about it. Okay. Blood. Okay, blood is a connective tissue. What 3 things must it have, Christina? What 3 components does it have to have? It's a connective tissue. It has to have ACE. Very good. Amorphous ground substance. What do we call it in blood? Luke?
Like plasma?
Plasma, the liquid portion of the blood, right? Cells. We have.
Red blood cells. White
Yeah,
blood
well, we
cells.
call them formed elements. Why?
Because several different
Platelets are not
platelets.
actually cells,
Right.
but fractured
Right,
cells.
yeah.
What's the cell that fractures and becomes platelets?
Not red blood cells. What? Megakaryocyte?
Megakaryocyte.
Yeah.
Megakaryocyte fractures, breaks apart, and becomes platelets. Okay, so we call them formed elements instead. So we're stretching this definition a little bit, and then we have extracellular fibers, Isabella. We have fibers floating around in our blood? No. So what the hell? Right? We have to have ACE, right? You said it. Amorphous ground substance, plasma. All right. Cells, formed elements. All right. We have that. Extracellular fibers. What are we talking about here? Soluble fibrinogen becomes insoluble fibrin during clotting. And therefore we have our connective tissue definition. Okay? So we don't have fibers floating around in our blood normally, but when we clot, that's when we form the fibers. From fibrinogen becomes insoluble fibrin. Okay? What breaks down the fibrin in a clot? Mike? What breaks down the fibrin in a clot? You form a clot, 25 hours after you form the clot, you produce a substance that's going to break that's fibrinolytic. It breaks down the clot. TPA, very good, excellent. Tissue plasminogen activated. Okay? All right, so blood. It's about 55% plasma, about 45% formed elements. Let's go up to the plasma. We have plasma proteins. What's the most abundant one? Dana? Albumin. What albumin does is it carries metal ions in the blood. It's also the most important thing it's the most important protein in the blood for capillary colloid osmotic pressure. Capillary colloid osmotic pressure is what draws the fluid back into the capillary. Why does the fluid leak out and then you got to draw it back in again? What is the purpose of that? Cam? Yeah, you're bringing all this nutrients, oxygen to the tissue, it leaks out, and then you draw it back in again. Why? You try to take away the metabolites. Okay, that's the purpose of why you're losing in the capillary bed, you're losing some fluid, and then you pull back in. Do you pull all of it back in?
No.
No, till 2 millimeters of mercury pressure is lost in the loose connective tissue. Where does it go? Lymphatic system. Okay, so now you're going to channel this fluid, the lymph. Now it's called lymph. When it's in the blood circulatory system, it's called plasma. When it leaks out, we call it lymph. And now we're going to channel it through lymph nodes, which are, again, what do you have there? Checking for any foreign things, right? Okay. So as it drains from an area, all the roads, all the different lymphatic vessels are coming into the lymph node. Lymphatic capillaries are coming to the lymph node, and then you have surveillance. Okay. And if there's something wrong, you get a swollen lymph node. Why do you think your lymph nodes are chronically swollen in your throat?
You're always eating and breathing.
Eating and breathing pathogens. Okay. All right. Then we have globulins. We have alpha and beta globulins. They transport metal ions. And then we have gamma globulins. Another name for that is antibodies or immunoglobulins. Okay. What do antibodies do? Alyssa, what do they do? What's the purpose of an antibody? What's that? Yeah, it's a kill me sign. It's a post-it note that gets slapped on something that says kill me. Okay? It's so the rest of the immune system can recognize it and destroy it. That's what the antibodies do. What are the 5 classes?
NBCE.
IgG is the most common. What's its purpose? Activates complement. Has a receptor on neutrophils and macrophages. Okay. It's the most numerous. Okay. What's that? Yeah, this is IgG. Okay. How about IgM? It's the first one made. It's a pentamer. In other words, there's 5 of them joined together with the J chain, right? It's the best at activating complement in the classical pathway. IgE, allergic reactions. Receptors are on what? Which cells have receptors for IgE? Mast cells and basophils. Okay. And then we have IgD. What's the purpose of an IgD? Canero. Dime. Hey, did you have your baby? Yeah, he did. Congratulations, Papi Chulo. Well, Papi Chulo is probably not the right. It's more like Super Papi. Congratulations. So getting back to IgD, IG Daddy.
There you go.
Is what? No. IgM and IgG activate complement. Sheila? Now you're close. B cells. Acts as a receptor on the B cell. Okay, that's the only known function of IgD. IgA, where are you going to find IgA, Isabella? Brace?
In breast milk.
Yeah, secretions. Any secretion. So whatever you're secreting in your digestive tract, whatever you're secreting onto your skin, tears, breast milk is going to have IgA in it. Okay, and that's usually a dimer. Sometimes it's a monomer, sometimes a trimer. What do I mean by dimer? It means there's 2 antibody molecules and they're joined together. Trimer, I don't have 3 arms, so that would be 3. Monomer would be just 1. Okay, pentamer would be 5. That's the IgM. All right. We have complement proteins. Where are they made? Yes, sir.
Can I just ask real quick? Which one
crosses the placenta or something?
IgG.
Okay.
That's the one of the other thing I was trying to think of. I was
Okay.
like, another thing IgG
All
does.
right, yeah, I knew
It's the only one
did
that crosses the placenta. Okay. So in hemolytic disease in newborn or erythroblastosis fetalis, IgG is what's implicated in that. So if you get a question on that, where it crosses the placenta and kills the baby's blood.
Yeah.
So when you have an Rh negative mother, Rh positive fetus for the second pregnancy, it can cross the placenta and kill baby's blood.
And babies only have IgM or something at first, or like?
Well, they start making IgMs when they start getting exposed to things, but basically when they're first born, they have IgGs. That's it.
Oh,
And then
okay.
they get IgAs for breast milk.
Okay.
All right.
I'm not in.
Fine. Not that bad. So we have complement. Where complement proteins made? Eric? The liver, very good. Okay. Remember you have C1, C2, C3, C4, C5, all the way up to C9. All right, we're going to do complement later, so I don't want to bore you with it. Yeah, propitin also is a complement protein. And you have factor D, factor B, remember the BB2, H2O, you know, all that stuff, C3A. All right, so we'll get into that. Fibrinogen, okay, is also made by the liver. This is used in clotting. And you have some regulatory proteins like enzymes and hormones. Then you have some electrolytes, things like sodium, potassium, calcium, magnesium, bicarbonate, blah, blah, blah. Organic nutrients like glucose, amino acids, fatty acids as well. How do fatty acids and cholesterol, how do they travel around in the blood? Cam, what do they need?
They get attached to like a
Protein, very good. They get coated with a protein. What are they called? What? A lipoprotein, right? So things like chylomicron, VLDL, LDL, IDL, HDL, those are all lipoproteins, okay? Organic nutrients, organic waste, so you're gonna have urea, ammonia, that kind of stuff. Bilirubin, creatinine. And then we have our formed elements, okay? So we have our red blood cells, which are the most numerous, okay? You have somewhere around 4.5 to 6 million per cubic centimeter or cubic, what is it measured in, do you know? Okay, whatever they measure it in, okay? You have 5 to 10,000 white blood cells. There are 5 basic white blood cell types. You have neutrophils, which are the most numerous. So what's the way to remember this? David? Never let my engine blow. 60, 39, 30. So 60 is neutrophils. What's the L stand for? Lymphocytes, okay. Never let my monocytes, engine, eosinophils, basophils are going to be less than 1% usually. Okay. Remember, it's a percentage. So if they give you a question on, you know, if I asked all the ladies to get up and leave, what would happen to the percentage of men in here? It would go way up, but the number of men did not go up. Okay, so you got to remember that when you're looking at a differential, you want to see, you know, if you see elevated neutrophils, you would think bacterial infection. So what do you want to check on the patient? See if they have fever. Okay, they should have a fever. If there's no fever, maybe something's depressing the lymphocytes. So something like corticosteroids will depress the lymphocytes and give you a higher differential count of neutrophils. Any questions on that? You sure? All right. All right, red blood cells. So, or basically this is how everything happens, right? So you have your hemocytoblast, a pluripotential hemopoietic stem cell, which is in the bone marrow. And then this divides into either a myeloid progenitor cell or a lymphoid. The lymphoid is going to go on to become 3 things: a T cell, a B cell, or a natural killer cell. Done. T cells and B cells have specific receptors for a specific pathogen. Natural killer cells are equal opportunity killers. Okay? They're not part of a specific immunity. Okay? They cause apoptosis. They have what are called perforins, which cause pores to form in the cell membrane of pathogens, and then they just fall apart. Okay? Then we have your myeloid stem cell. Your myeloid stem cell can become an erythrocyte or a red blood cell. It can become platelets, it can become basophil, eosinophil, neutrophil, or a monocyte. By the way, you see the word fill, or you see the suffix fill in the name of a white blood cell, it means it's filled with granules. So it's called a granulocyte. This is an old crappy term when we had crappy microscopes and we couldn't see the granules in lymphocytes and monocytes. Okay? Now monocytes and lymphocytes are called agranulocytes, but they're not agranular. But that's what they're called. So if you get a question on which of the following is an agranulocyte, it has to be a monocyte or a lymphocyte. Granulocytes have the fill at the end. So basophil, eosinophil, and neutrophil. Okay? If erythropoietin is stimulating this myeloid cell, it's going to become an erythroblast, proerythroblast. It's going to eventually become an erythroblast where you're going to get rid of your organelles and it becomes an immature red blood cell called a reticulocyte. Remember, the reticulocytes in your circulation are usually less than 1%. 0.8% to 1%. When would that go up? Rebecca?
Some sort of need for.
Yeah, when there's an emergency, you need more oxygen. Okay, so you get on a plane today and fly to Denver, your reticulocyte count is going to go way up. Okay, why? Because now there's not enough oxygen in the air to support what you're trying to do, so now you release the kids, you push the kids out there. Okay? Think of it as, you know, these civil wars in these countries that are going on for like 20, 30 years. You see, you know, grandpa with no leg on, you know, with a machine gun, and you see the little kids with the machine guns. You don't see these young guys because they're all killed, they're all dead. Okay? So the little kids are pushed out. Those are the reticulocytes. We said this before, the myeloid cell becomes a megakaryocyte and that fractures into platelets. And then this is very complicated. Basically, you have what are called colony stimulating factors, and that's going to guide whether or not you're going to get a eosinophil, a basophil, a neutrophil, or a monocyte. Okay? Any questions on this? All right, red cell production. So hypoxia in the renal tubule and in the liver, these are hepatocytes and perisinusoidal ETO cells. I don't know if you've seen this when you study. These pick up hypoxia and they release what? EPO. It's the phone call, very good, to the bone marrow, make more red blood cells. Okay? So about 80% of it is made where? Kidney. Okay, so in this case, the liver has less of a role, but it is made in the liver as well, 20%, but about 80% is made in the kidneys. That's why you'll see people who are on dialysis actually have to get EPO injections. You've heard of Procrit, the drug? I don't know if you've heard of it. Procrit is erythropoietin. Okay? So it stimulates the cells to increase EPO or erythropoietin. 20% of it's made in the liver, the rest is made in the kidneys. They arise in the bone marrow from the pluripotential hematopoietic stem cells. They become myeloid progenitor cells. 1% or less of the circulating red blood cells are immature reticulocytes. They lose their organelles and the nucleus in the erythroblast state of stage of development. So they resorb their organelles. So it's the only cell that doesn't have the MHC. It's the only one that doesn't have any organelles. Okay? You see it's a biconcave disc. What's the basically what is this for? carry on.
Carry on.
Okay? And that is done by hemoglobin. So you have 2 alpha and 2 beta chains, and you have 4 heme groups. The heme group is made up of these porphyrin rings. These are called porphyrin. And then you have the iron in the middle, which is going to bind the oxygen. Blood types. So you have 4 basic blood types. You have type A, type B, type AB, and type O. Type A has surface antigens of A, and you automatically code for B antibodies. Type B, you have surface antigens B, you automatically code for type A antibodies. Type AB, you have both surface antigens, so therefore you don't make any antibodies, otherwise you kill your own cells, okay? Type O has no surface antigens, but you make both A and anti-A and anti-B antibodies. How do they test for this when they're doing a transfusion? They always do this agglutination reaction. They take the red blood cells of the donor and the plasma of the recipient, and they mix them, and then they do this the opposite. They do the plasma of the donor and the red blood cells of the recipient, and they see if there's an agglutination reaction. Yes, sir.
So is AB the universal receiver?
Right, why?
Because
Because you're not making any of the antibodies. So no matter what I put into this person, you're not gonna have any antibodies that are gonna destroy these cells.
So that would be the universal zone.
Oh, because there's no surface antigens.
Oh,
Okay, but if I put AB into an O person, what's gonna happen to that? It's gonna get destroyed by these antibodies. You see that? Or not?
So if you put in B, you would destroy.
I'm gonna destroy these B cells. Why are you getting a transfusion? Because you're in deep shit, right? You need blood, all right? So they don't want to put blood in you, and then your immune system is going to destroy you. You're going to be worse, shit, right? So if I took B and put it in O, what's going to happen is you're making anti-B and anti-A antibodies. So you're going to destroy this cell. You see that? But if I take this O cell and put it in here, here, or here, nothing's going to happen because there's no surface antigens.
So the type O people need type O blood.
Right.
Gotcha.
then the whole, was it RH factor or something?
That's another
comes-
thing. That's, yeah.
comes
So it
into
has to
play.
be RH negative or RH positive. That has to match also. Otherwise, you'll kill it. Okay. All right. What is this happening here? Why is this happening? Myra, ¿por qué? Tell me why this happens. You get this lysing and this clumping and everything. What's being activated? Complement. Remember, complement results in oxidation, inflammation, and
Lysis.
lysis. Okay, so this is a complement reaction. Therefore, these antibodies have to do what class? What's that? IgG or IgM. All right. All right. This is erythroblastosis fetalis, or hemolytic disease of the newborn. First pregnancy, mother is Rh negative, the baby is Rh positive. Nothing happens because the blood doesn't mix. But during delivery, there's hemorrhage, and the mother is exposed to the baby's blood, so she starts making anti-Rh antibodies. If these are IgGs, what can they do in the second pregnancy is cross the placenta and lyse the baby's blood. What's the drug that they give to prevent this? Anyone remember? Rogan. R-H-O-G-R, I think it's R-H. R-H-O-G-R-A-M. Rogan. R-H-O-G-A-M, sorry. Okay, Rogan.
We need to know treatments for boards or.
Maybe. Who the hell knows? Usually not, but they might throw it in there. Listen to me, you're gonna get questions that you've never heard, like, what the hell are they talking about? Where did they get this? They just come up with these bullshit questions, you know.
That's good.
Part of it is that, I mean, imagine 3 professors from 3 different schools, and some there's a moderator there, so from a local college or whatever, And what happens is, one person in the group inevitably has to impress everybody. So they have to talk about shit that nobody's ever heard of, and it doesn't matter. You know, so they're like, well, as a matter of fact, the eto cells in the liver, you know, like that kind of, why did I right? So that's how these shitty questions get in there, I think. You know, so it's sort of a gotcha question, like, you know, look how smart I am, I made this question that nobody knows. So, you know, you're gonna get some of those questions, just go like, well, whatever. You know, if it's the liver's on there, pick the liver. All right, but if it's not on there, then just, you know, go like this, and then move on, like all of it. You're gonna know so much of this stuff. You're gonna be so good at this, that you're gonna rock this test. You're gonna do great on this. So the fact that you're sitting here right now means that you really care and you've been studying during the summer, hopefully all summer. But you learned it the first time. It's just basically a refresher, hopefully. All right. All right. So clotting. So you have the vascular phase. You cut the vessel. It spasms to try and slow down the bleeding, the hemorrhage, and then you have what's right in here. What is this? That's loose connective tissue. Here's your endothelium right here, and here's your loose connective tissue. And here's your muscular layer, okay? So what happens is, you have release of chemicals, ADP, thromboxane A2. What is thromboxane A2? What does that derive from? It's an eicosanoid, but what's it derived from? What's it derived from? It's derived from arachidonic acid in the plasma membrane. So it's in the plasma membrane of platelets. When a platelet gets stimulated, so platelets just, you know, cruising around in the bloodstream, like woohoo, the backstream, whatever, and it's going around. And then what initiates the platelet to get stimulated? What stimulates that platelet?
Von Willebrand factor?
Sounds German.
Von Willebrand factor?
Von Willebrand factor, very good. So what happens is, when there's an exposure of the collagen fibers in the loose connective tissue here, and it sticks out into the lumen, von Willebrand factor attaches to it, and then that attaches to a platelet. That's going to activate the platelet. The platelet is going to make thromboxane A2 from the arachidonic acid. What that does is it now causes the glycocalyx on the surface of the platelet to become sticky, and other platelets start to pile on. Okay? And then that's going to help make this platelet plug. At the same time, we're going to convert fibrinogen to fibrin. And that's a whole thing that we'll go through. Okay? But what initiates it? The collagen fibril. Okay? Any questions? So, like I said, the collagen fibril is sticking out. That causes the platelets to get activated through von Willebrand factor. Okay? Now, also that collagen fibril sticking out is going to activate the intrinsic pathway, which is a little bit longer than the extrinsic pathway. So it takes a little bit longer to happen. Both are happening at the same time. It is activated by factor 12, which is Hageman factor. So Hageman factor is activated by the exposure of the collagen fibril. Okay? Platelet factor 3, which is made by the platelet, calcium ion also, and then you have other clotting factors. All of these are made in the liver. A lot of them are vitamin K dependent. If you have a kind of vitamin K deficiency, you can have hemorrhage. Or if you have something like warfarin or coumadin, like let's say your dog accidentally eats rat poison, which is warfarin, they can start hemorrhaging all over the place because it's an vitamin K antagonist. Okay? So it comes together at factor 10, which is called Stewart-Power factor. There's two different forms of this prothrombin, this factor 10 ACE, which is the enzyme that converts factor 10 to prothrombinase. So you have the intrinsic pathway, and notice that's made up of platelet factor 3, Hageman factor, calcium, factors 8 and 9, and that's gonna form a complex that activates factor 10. And then on the intrinsic pathway, the damaged tissue releases something called thromboplastin, or tissue factor. Okay, tissue factor or factor 3. That is going to combine with calcium and also 7. And then that's going to cause a different complex that is going to cause factor 10 to become prothrombinase. From there, it's the same. Prothrombinase converts prothrombin into thrombin. Thrombin converts fibrinogen into fibrin. And now you have your insoluble fibers in the blood, which are going to form a mesh and trap the platelets and the red blood cells, and then the platelets can contract and pulls everything tight. And 25 hours later, you make, Michael?
Wrong, so I'm gonna have to say that one, I'm sorry.
What do you make 25 hours later to lyse that clot?
Oh,
TPA, tissue plasminogen activator. Okay? I was gonna do the YMCA thing, TPA. Okay. All right, how you doing? You need a break? What time we got?
147.
148. I'm gonna go a little longer, right? No, I'm gonna break. All right, take a break. Dark. Okay, here's your myofibrils. Here's your myofibril. You have your sarcolemma is the plasma membrane, and then you have these invaginations called T-tubules that go down through the muscle cell, but this is still outside of the cell, believe it or not. And you have your sarcoplasmic reticulum, which is the smooth ER of the muscle cell. Anything sarco means skeletal muscle. And then you have these areas that are enlarged here called terminal cisternae, and that's where you're going to have most of your calcium stored. You have about 40,000 times the calcium in here than you would have in the cytoplasm. Okay? And it's held in there by calsequestrin, is the protein. So as it receives a signal, okay, you release acetylcholine from the motor neuron releases acetylcholine, it goes across the synaptic cleft, binds with a receptor on the plasma membrane. That's going to cause depolarization of the membrane. Depolarization goes down through the T-tubules, causes the release of calcium from the sarcoplasmic reticulum. Okay? Any questions on that?
The depolarization is caused by sodium, right? And calcium comes after it's starting.
Well, the calcium is inside the cell in the sarcoplasmic reticulum, and it's held by the calsequestrin. So the calcium, you're thinking of heart depolarization right now. When the muscle depolarizes, it opens up the sodium channels. That's it. And then that wave of depolarization goes down the T-tubule, and that causes the calcium to be released from inside the cell. So there's no extracellular calcium coming in. That's in the heart, you have the extracellular calcium. Okay? Good question. All right, you have your A band, your I band. If you haven't done this, I would try drawing this a couple times again. Okay? So your zone of overlap is in the A band. The part that doesn't overlap is called the H band. The M line is in the middle of that. That's made up of myomesin. You have the lattice, this elastic lattice that attaches the myosin to the Z disc. That's called titin. That's the core protein here. And then you have your actin is the red lines here. During contraction, what gets smaller is your I band and your H band. What stays the same is the A band. What gets larger is the zone of overlap. Any questions on that? You can see like 5 multiple choice questions right there, And depending on where you are with this, so, on the Z line, you're gonna have, alpha actinin attaches the actin to the Z disc. Here's the actin and attaches it to itself, and this is the titin, the green dot in the middle. In the middle of the I band, you're gonna have both the actin and the titin. In the zone of overlap, you can have both the actin and myosin. In the H band, you're only gonna have the myosin, and then the myomesin is what's attaching the myosin together. Yeah,
Can you go over the, what gets bigger and what stays the same again?
sure. The only thing that gets bigger is the zone of overlap. So think about it. Here are my actin and myosin. You look here, and then when it contracts, there's more overlap. Right? So that makes sense, right? That the zone of overlap is going to increase. What gets smaller is the I band and also the H zone. Okay, so if we go back here, or the H band or H zone. So this is going to get smaller, and this is going to get smaller because you're pulling this and this, right, together. And then what stays the same always is the A band.
Okay.
Okay?
Thank you.
So skeletal muscle, again, you have from the largest sphere, you have the epimysium, the perimysium, and the muscle fibers surrounded by the endomysium. And then the myofibril is what has the sarcomeres. Remember, sarcomere is from Z to shining Z. Okay, Z disc to Z disc. That's the definition of a sarcomere. It's the functional unit of the skeletal muscle. Okay. So if we look a little bit closer at the red line here, that's the small filaments. Okay, that's the actin. The actin is actually two F strands wrapped around each other. So think of the F actin strand as a pearl necklace, and you have two of them, and they're twisted around each other. That's what makes up the actin. Each individual pearl is called a G-actin molecule. And on those pearls, you have this yellow spot. That's the active site. What blocks that active site is the tropomyosin. And what's associated with that is the troponin. What's going to happen is, remember before we said we release the calcium from the sarcoplasmic reticulum? That's going to bind to the troponin and move the tropomyosin out of the way and allow the myosin head to attach to the active site of the G-actin molecule. Also, another thing, in the middle of this, you have something called nebulae. This is a protein that's in the middle that these two pearl necklaces, the F-actin strands, wrap around. All right? And the thick filament is the myosin. Here's your M line that's made up of myomesin. And then you have the little heads. These myosin heads will attach to the active site. So here's the sarcomere at rest and sarcomere during contraction. Now you notice the I band gets smaller, the H zone or HB band gets smaller. The A band stays exactly the same, but the zone of overlap all increases. Okay? So, sarcoplasmic reticulum releases calcium. What causes it to be released, Isabella?
The depolarization.
Depolarization wave, right? So that's coming down the T-tubule, this, and the T-tubule is right next to the sarcoplasmic reticulum, the terminal cisternae, where it's bulged out a little bit, it's enlarged, and that causes the release of calcium from the calsequester. Okay? The calcium is going to bind to the troponin. That's going to move the tropomyosin out of the way, and here's your active site. And then the myosin head is going to cross bridge and attach. Now this has to be activated by ATP. So you split ATP into a phosphate group and an ADP, and that activates the myosin head. And then to release, you also need ATP. So you talk about rigor mortis. So rigor mortis, the reason why people get rigor mortis is because you can't detach, you're not making ATP anymore, so you can't detach from the muscles, can't detach the myosin from the actin within the muscle. and that causes the stiffness. And then as the body starts to get broken down by bacteria, then it'll soften up again. So the rigor mortis is, do you know what the time period is for that?
The first one sets in 2 hours.
And then it lasts about,
It lasts a few hours, and
Yeah.
then there's a second, a third.
and then you start to break down the tissue. You actually decompose it at that point. Okay? Not you, somebody else. All right, so here's your resting sarcomere. Again, you have the troponin with the tropomyosin. The tropomyosin is covering the active site on the G-actin protein, G-actin molecule, which is part of the F-actin strand. Calcium binds, it moves the tropomyosin out of the way, and then notice this is split already. The ATP is split. It's all ready to go. It's charged up. Now it's going to reach out and grab the active site and attach to it, cross bridge formation, and then it moves. Notice it's moving it this way, to the left, moving the active. And then myosin reactivation with ATP, ATP gets split again, and that causes it to release from the cross bridge. Any questions on that? Well, creatine is a storage molecule for ATP within this, and creatinine is the waste product that's cleared by the kidneys. So, hey, how are you? Creatinine is the gold standard for measuring kidney function. When your creatinine levels get to a certain amount in the blood, then you have to go on dialysis or you need a kidney transplant. Right? It's a waste product from muscle, but it's used to measure kidney function. Right? All right. So cardiac muscle is very similar to skeletal muscle, but there's some important differences. So it is a striated muscle fiber. However, instead of having hundreds or even thousands of nuclei, generally speaking, it has only one nucleus. Right? It's also branched. You see there are kind of branches in this. Okay? And it has these intercalated discs, which are going to hold it together and also allow ions to flow from one to the next. So the tissue can act as a syncytium. Syncytium means that the tissue acts as a unit. So what does that mean? When you have the SA node fires, it's going to spread across the entire atria, both the right and left atria, okay? And then it's going to contract as a unit. That's called the syncytium. As that passes through the AV node, it slows down, giving it a chance to contract on the top, and then that's going to go down the Purkinje fibers, which are the fastest conducting fibers in the heart, and come back up, down through the bundle branch and then up through the Purkinje fibers, and causing the contraction of the ventricles. So that's why you have the atria contract as a unit, then the ventricles contract as a unit. If that does not happen, then you're in fibrillation. You're either in atrial or ventricular fibrillation. Atrial fibrillation is dangerous in that you can form clots in the atria and they can wind up as a heart attack or a stroke. Ventricular fibrillation is you are going to die within minutes if you don't get that fixed. That's what a defibrillator is for. So these scenes in a hospital where it goes, nothing's happening, that's not when you defibrillate. Defibrillation stops the heart. You don't want to stop the heart when it's already stopped. Okay? So what they would do in that case is give you lots and lots of epinephrine and start pounding on your chest to try and get your heart going again. But when it goes, that's not when you defibrillate. You defibrillate when you get that, raggedy. It's basically what's happening is you have different parts of the ventricles are depolarizing at different times. So it's just going like this instead of contracting as you would. So the word is syncytium. Okay, I'll be surprised if you don't see that one. Okay?
Spell that.
Sorry?
They spell that.
SYNCITIUM. SYN. CITIUM, does that sound right? Syncytium, right? Notice also that the sarcoplasmic reticulum is much less developed in the cardiac muscle. You also don't have triads, you only have dyads. So you have T-tubule with a part of the sarcoplasmic reticulum. The reason why it's not as developed here is because the calcium, instead of coming from inside the cell, it's coming from outside of the cell. So cardiac muscle cell stores this calcium in the T-tubule. Where is it stored in the skeletal muscle? The sarcoplasmic reticulum, inside the cell. Okay? All right, so this is the oxygen hemoglobin dissociation curve. So, remember, pH is going to be opposite of diphosphoglycerate and also the opposite of temperature. Okay, so when you have a lot of acid, that's going to cause the pH to go down. What causes acidity in the blood? Well, hydrogen ions, where do they come from? More specifically? Carbon dioxide. Carbon dioxide doesn't have any hydrogen, right? So where does it come from? Carbon dioxide combines with water, and it forms carbonic acid. And then that dissociates into hydrogen ions and bicarbonate. I'm sure you're going to get a question on this. Where the hell is my little bacon?
Oh, yeah.
Oh, here it is. So you have CO2 combines with water. What's the enzyme? You're gonna get this. Carbonic anhydrous.
Yes.
And that forms H2Cl3. This is carbonic acid. Okay? And then that splits. What's it going to release? It's an acid. It releases hydrogen ions, right? Plus HCl3 negative. This is bicarbonate. Okay? And notice this is reversible. How do you reverse it? You start breathing heavily and you blow off the carbon dioxide, and that's going to reverse this. And it'll blow off some of the acid in your blood, okay? And that will cause you to become more alkaline. Okay? So when you think about this, what's causing the pH to go down or become more acidic? Why are you becoming more acidic? Because you have a buildup of carbon dioxide. So what do you think is going to happen to hemoglobin and oxygen? You're going to unload more oxygen from the hemoglobin. It's going to cause more to release. So, diphosphoglycerate and temperature are also, an increase in those are also going to cause more oxygen to release. So the way to remember this is that pH is going to be the opposite of the other two. And how do you get your pH down? Too much carbon dioxide. If you have too much carbon dioxide, then you're going to start releasing oxygen from hemoglobin. Okay? Any questions on that? I'm trying to get you to logically, instead of trying to memorize this, I'm trying to get you to logically think through this. All right, anyone have any questions on this? All right, if we look at cardiac muscle versus skeletal muscle size, skeletal muscle is going to be much larger. Nuclei, you usually have only one. There's going to be hundreds in skeletal muscle. Sarcomeres are going to be the same. You're going to have sarcomeres in both, I should say. Short T-tubules in cardiac muscle, this is where you store the calcium. There's no triads, they're only called dyads. Triads are formed with the cisternae of the sarcoplasmic reticulum, and two of them with one T-tubule is called a triad. Mitochondria are going to be more abundant in cardiac cells, obviously, because You're not sitting there going like this all day long during your sleep with skeletal muscle, right? But with your cardiac muscle, you're constantly going, right? So you're gonna need more mitochondria. Myoglobin, lipids, glycogen, very little myoglobin in the skeletal muscle, a couple lipids, but a lot of glycogen. Blood supply is going to be more extensive than cardiac muscle. It is extensive in skeletal muscle, but not as much as cardiac muscle. Okay, so smooth muscle is non-striated, is another name for it, okay? There are no striations in this. The dense bodies are analogous to the Z-disc. And notice that you have actin and myosin, but they're not arranged in the same way. When this contracts, notice that the entire thing contracts and gets smaller. And it has what's called a latch mechanism. Once it contracts, it can stay contracted without using any energy, and then it relaxes. So it's very slow to contract, very slow to relax as well. As you may have experienced if you've ever had an abdominal cramp, okay? It's like it starts to come on, you're like, whoa, and it's like, all right, let go already, and then it starts to like, whoo, well, oh my God, right? So I hopefully you've had an abdominal cramp sometime in your life.
Yeah.
Me, because you never had that.
Yeah, no,
You've never been sick.
no.
But basically, the abdominal cramp is a good example of how a smooth muscle cell works. Slow to contract, and you have that latch mechanism which holds it, and then it relaxes. Okay? The calcium binds to what are called caveolae. It binds to calmodulin, which and they have these little depressions called caveolae instead of T-tubes. Okay. All right. Circuitry here. So from the lower part of the body coming up to the inferior vena cava, from the top part of the body coming down to the superior vena cava into the right atrium. Then it's going to go to the right ventricle. Then it goes to the pulmonary system, gets oxygenated, and then comes back to the left atrium down to the right ventricle. I'm sorry, left ventricle, and then out through the aorta, up to the head, and down through the rest of the body. This is pretty. If you don't know this, where the hell have you been in the last 2 years, right? So it's pretty self-explanatory, right? What you need to know here, probably, and you probably already know this, the only vein that is oxygen rich is pulmonary, and the only artery that is poor with oxygen or has low oxygen is the pulmonary as well. All right, so we already talked about this, but we'll just do this quickly. So the activity, these cells are autorhythmic. So if you cut the vagus nerve and the sympathetic nerve to the heart, actually it will actually speed up because you have what's called vagal tone, which slows the heart down a little bit. But basically these cells are acting on their own. So I don't know if you remember, they don't do vivisection anymore, right? Live dissections. So when I was in, I remember this in junior high school, we had live frogs, and we picked the frog and then we dissected it alive. And it was horrific. I actually burst into tears. It was horrible. See this little frog is like squirming, and you cut the neck and the blood dripped down through his, and then he picked it like that. You know, you take a big needle and stick it right through the whole spinal cord, and then it just makes it paralyzes it. And then you open it up and all the organs are still going. And he actually cut the heart out and put it on a sponge, and it was still beating away for a while, maybe a minute or two. But that's what they used to do to kids. Pretty traumatic. That now I'm vegetarian.
But like, why?
It's just a sick, it's crazy, you know, people just, back then there was no regard for animal life. It was just like, you know, sure, we'll just do this too. And then it was like, okay, everybody team up and kill your frog now. Like, no,
Next week's pigs.
so fetal pigs, they actually take the sow when she's about to give birth, and they slaughter her, and then they take out all the fetal pigs.
Yeah, we did that.
And they throw them into formaldehyde alive. while they're still alive. So they take it right out of the uterus, throw them in formaldehyde, and then, you know, let them die in the formaldehyde, and then you get them as your biology student. Yes, great stuff.
Yeah.
So anyway, so I don't know how we got there, but SA node is autorhythmic here, depolarizes, spreads across the atria. Just make sure this is not home. Gracious, my daughter. And then it's going to get slowed down at the AV node, and then go down through the bundle branches, and then the Purkinje fibers are the fastest fibers. And so as it depolarizes, there's a 100 millisecond delay at the AV node, and that allows it to come down to the apex of the heart, which is the bottom of the heart here, the pointy part, and then it's going to come back up through the Purkinje fibers, and then depolarize the ventricles. So you get that contraction of the atria, then the contraction of the ventricles. Okay. If we look at the EKG here, we have the P wave is atrial depolarization. The PR interval actually goes from P to Q. I don't know why the hell they call it that. It's just stupid. But anyway, it goes from the PR to the PR. What's happening from here to here is what? Can someone explain it? Right.
What did you point to?
From during the PR interval, what happens?
Well,
No, atrial depolarization. The P wave, right? Atrial depolarization, and then it gets slowed down and goes through the AV node and down through the bundle branches and down the Purkinje fibers, and then you get the QRS, which is the depolarization of the ventricles. So all of that happens in this PR interval. Okay? So if you have something that extends the PR interval, it means that it's getting slowed down too much in the AV node. Okay? QRS is the depolarization of the ventricles. At the same time, you're getting repolarization of the atria. And then the T wave is the repolarization of the ventricles. Okay? All right. So why do you go from negative 90 to positive 30? What's happening in one? Myra? Sodium's entering. So you open the sodium channel, sodium rushes in from the outside, right? Maybe you have a lot of sodium outside the cell, very little inside the cell, you have mainly potassium inside the cell, right? Why does during 2, calcium enters? See, now this says, and there's closure of the slow calcium channel. So calcium starts rushing in, but why does it stay basically the same? There's a plateau phase. Why doesn't it plummet down and become, or why does it become much more positive? You're getting a too positive ion that's rushing in. Why doesn't it do that? Why does it become more positive? What's that?
Can't contract right away.
Well, it can, because it's not going to contract till you get it's contracting here, then this is the absolute refractory period. But why is this line flat or relatively flat?
It's just how the heart
Just the
controls
way it
itself.
happens. But
Yeah.
why?
Something with
The
a
reason why
myocyte-
I'm asking this is because physiology-wise, I want you to know this, because this might be on the test. What has to be happening? If positive is rushing in, it should make this more positive. So what has to be happening here? Positive has to be leaving. What positive is leaving? Potassium. So as the calcium is rushing in, potassium is leaving. Okay? And then once the calcium channel's shut, then the potassium keeps going out, and that's what causes this to drop down and become negative. Okay? So this plateau phase is calcium is rushing in, so you would think it would keep getting positive, but it stays relatively the same, it actually gets a little negative. And the reason is because potassium is leaving too. And that's what this doesn't show. All right. By the way, did you get this all? I sent this to you and you gave it to everybody. This is great. This is called the Wigger diagram. This is great for showing you exactly what's happening at what time during the EKG and the cardiac cycle. So if you understand this, you definitely understand the cardiac cycle. So you have atrial depolarization, right? And then what happens is the atria start to contract. And so what happens to the pressure in the atria? Goes up, right? And then as the blood is leaving the atrium, about 75% of it just falls into the ventricle, right? Because of gravity, and the rest is pushed in by atrial contraction. And now there's really no blood left in the atria, right? And now that's in the ventricles. And then you have the QRS, which means that the ventricles have now depolarized. So the ventricles start to contract. And then what closes here at number 3?
AV valve.
The AV valve is going to close because the ventricular pressure has overcome the atrial pressure.
Is that S2? What's S1?
No, that's S1.
Yeah, guys, S1. Come on. Get to that.
Okay. Now you have what's happening to the volume of blood here. Dana, during this part here, between 3 and this and right here. What's happening to the volume of blood in the ventricle? Stays the same. Why? Because the AV valve is closed and the aortic valve is closed. So the entrance and exit of the ventricles are closed and it's contracting. So why does the pressure go up so quickly? Because the blood's not moving anymore. And what do you have to do? You have to overcome the pressure in the aorta to get the AV valve to open. I'm sorry, the aortic valve to open. Okay? So right here to here is where you have injection of blood into the aorta. Any questions on this, Cam?
So why does it keep going up after it opens? So I know where the aorta pressure would.
Think of a water balloon full of water, right? You puncture it and then you squeeze it. What's going to happen? You get this big, it starts and it goes, right?
Yeah.
And then as you start running out of water, what happens? It starts to go down. That's what's happening here. Goes up, you're pushing out a lot of blood, and then as it starts coming down, the aortic valve closes. And now, again, the volume between here and here stays the same. This is isovolumetric contraction. This is isovolumetric relaxation. Okay? Iso just means it stays the same. All right? And then your AV valve opens and you start getting filling of your ventricles. So filling of the ventricles is from here all the way across to here. Any questions on that? All right, so you have parasympathetic and sympathetic stimulation of the heart. Parasympathetic is coming from the vagal nucleus through the vagus nerve. Excuse me. What it does is it slows the heart down. Sympathetic is coming from T1 to T4 from the lateral horn. It comes out and synapses, and then you have your first your pre-ganglionic sympathetic fiber and your post-ganglionic sympathetic fiber. Obviously, sympathetic is going to cause an increase in rate, an increase in strength, and more blood. You know, your ejection fraction is going to go up. It's going to increase the pumping of the blood. All right. Preload. This is the end volumetric pressure that stretches the left ventricle of the heart to its greater geometric dimensions under variable physiological demand. So as you're loading the blood into the ventricle, it stretches. That's preload. What's gonna happen if it stretches? It's gonna rebound, right? So you get this stretch, it's called the Starling law, right? As it stretches, it's gonna rebound and you get a better contraction of the heart. You get more blood out, a higher ejection fraction, okay? Afterload is the pressure that you have to overcome to get the blood out of the heart. So in the left ventricle, it's the pressure where? Josh? You look like you're at the stage. No. If we're talking about the left ventricle, what's the pressure you have to overcome? No, where? What's the pressure where? I'm in the left ventricle and I want to push the blood out. What do I have to push against? What's holding that valve closed? The pressure where? In the aorta. Okay, so the pressure in the aorta is the afterload. Okay? The pressure you have to overcome to push that valve open is called the afterload. Okay? Any questions on that? All right. Stroke volume is the volume of blood pumped from one ventricle to the heart with each beat. Cardiac output is stroke volume times the heart rate. So whatever the volume is you're putting out and your heart rate, that's going to give you your cardiac output. Starling law, the stroke volume of the heart increases in response to an increase in the blood filling at the end diastolic volume. So the higher the preload, the more blood that's going to be pushed out because you're stretching that ventricle, and then as it rebounds and starts to contract, you're going to push more blood out. That make sense? All right, respiratory phys. Herring-Brewer reflex. This is when you inflate your lungs. Okay, why don't you just blow your lungs up like a little bratty kid and you go, and you just blow your lungs up? Why can't you do that? Because there are stretch receptors in the bronchioles that when you stretch it to a certain point, it activates the pneumotactic center and it inhibits the apneustic center. So it basically shuts your lungs off. You can't blow up your lungs. Okay? Sometimes you do blow up your lungs, and that's called atelectasis, right? Yes?
Yes,
Okay.
of course.
So what it does is, they're pulmonary stretch receptors in the smooth muscle of the airways. And it prevents excessive stretching of the lungs during large inspirations, called the Herring-Brewer reflex. The apneustic center of the lower pons, what it does is it promotes inspiration by stimulating inspiratory neurons in the medulla oblongata. So it's a constant stimulus to breathe. That's the apneustic center. So this delays the switch off signal of the inspiratory ramp provided by the pneumotactic center. So the apneustic center and the pneumotactic center antagonize each other. So apneustic is your breathing in, it's stimulating breathing in, the pneumotactic center shuts it off. Right? Pneumotactic center is also known as the pontine respiratory group. These are in the rostral, dorsal, lateral pons. The colic-fused nucleus and the medial parabrachial nucleus are the nuclei that are involved with this. This antagonizes the apneustic center, cyclically inhibiting inspiration. So as you're breathing in, something tells you to stop because you've had enough, and that's the stimulation of the pneumotactic center, okay, or the pontine respiratory. So effectively, it decreases tidal volume and regulates the respiratory rate. Absence of this results in increased depth of respiration and decreased respiratory rate. Countercurrent mechanism. All right, so process by which interstitial fluid of the kidneys is highly concentrated, allowing for ADH and to be effective in water absorption at the distal convoluted tubule and the collecting duct. It mainly has its effect at the collecting duct. Okay, so basically what you're doing is, in the descending loop of Henle, the filtrate is going down, and the blood is in the peritubular capillaries is going in the opposite direction. And basically what you're doing is you're pulling out water from the filtrate and concentrating it. And then in the ascending loop, you're pumping out the sodium and chloride ions into the interstitial fluid. Do you want me to do a diagram of this? All lost souls. You have your efferent arterial, here's your glomerulus. The ascending loop is the thick segment, thicker. Okay, so you have your proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct, glomerulus is here. Okay. So what happens is, as the filtrate starts to go down, going in this direction, the peritubular capillaries are wrapped around this, and the blood is going this way. So the filtrate's going this way, and the blood is going this way, counter current. And what you're doing is you're pulling water out of this and going into the capillary. So what happens to the concentration here? It starts at 200. As you go further down, it's going to become 1200 inside this tube. Okay? Because you pull the water out of it. Okay? Now, the only part of this tubule that is impermeable to water is the ascending loop, thick segment. Okay? What you do here is you pump out sodium and chloride ions. Okay? So by the time you get back up here again, you're at 200. So what did you do? You started at 200 and you wound up at 200. So what the hell was the purpose of that? The purpose is that you pumped out the sodium and chloride ions around here to make this very concentrated. You have lots and lots of sodium and chloride all around here. So this interstitial fluid around this collecting duct in the cortex is going to be about 200, but as you go further down towards the medulla of the kidney, it's going to be much more concentrated. Okay, so now this filtrate is 200, it starts going down here, and you release ADH. Where's ADH made? What? Nothing is made in the posterior pituitary. It's stored in the posterior pituitary.
Hypothalamus.
Hypothalamus, what nuclei? What nucleus?
Ventral medial?
Is that?
Ventral medial? Ventrolateral?
The O's don't match, superoptic. Right?
Sure.
Remember this, the oxytocin and ADH are both made in the hypothalamus and stored in the posterior pituitary. The O's don't match. Superoptic doesn't match with the oxytocin. That's hard. Okay? All right, so it's made in the superoptic nuclei. It's released when you have too much concentration in your blood. And what does it do? It opens up these aquipores. So as this is going down, if this is 200, this is 400, you're going to draw water out. And as it gets more concentrated, it sucks more water out of the filtrate. So under the influence of ADH, you're going to have a very small volume of urine that's very concentrated. Okay? What prevents the release of ADH? Something that you crazy kids like to do. Alcohol. Okay? So that's why they say that you rent beer, you don't buy it. Because if you're drinking a lot, what happens is that all of a sudden you start peeing a lot, right? They say, oh, once you break the seal, it's that's bullshit. You're gonna start peeing like crazy anyway. So you pee a lot and you notice that it's very dilute and large volumes of it. And why do you wake up with a banging headache? Well, alcohol is poison. It will kill you in high amounts, all right? But also you're extremely dehydrated. So one thing to do is drink a lot of water before you go to bed if you go out on a bang. Okay? But so this is the countercurrent mechanism. Okay, so what's countercurrent is the filtrate is going down, the blood is going the opposite direction, and the blood is picking up the water from the filtrate, and that makes it more concentrated. Then you concentrate the kidneys, and that causes the ADH to work. If you didn't have this concentration here, ADH would be useless. Okay? You have three things that cause the formation of urine. You have filtration, which happens where? Glomerulus, okay? You have reabsorption, which is happening mostly at the proximal convoluted tubule. About 95% of the water is reabsorbed there. All of your glucose is absorbed there unless you reach the renal threshold, which I know you know is. Very good, 180 milligrams per deciliter. And then you're going to wind up spilling glucose over into the urine, and then it's going to make this urine much more concentrated. And that's why the ADH doesn't work so well, because now if this is 800, by the time you get down here, you haven't reabsorbed anything. That's when you start getting polyuria. When people have diabetes, they start peeing a lot, it's because they've reached the renal threshold. But remember that between 140 on 2 occasions or higher is considered diabetes mellitus. That's diagnostic. You can be fully 2 feet planted in diabetes. You have diabetes, but you do not have polyuria because you haven't met your renal threshold yet. You have to get to 180. So imagine, think about that. You can hold on to all of your glucose, every molecule of glucose, up to 180 milligrams per deciliter. Normal is 90 to 105. I'm sorry, 70 to 105. You're really holding on to, you are designed to hold on to glucose. And that's because we're designed to starve. Okay? And then you have secretion, which is happening mostly in the distal convoluted tubule. Digestion, your parietal cells or oxyntic cells that are in the stomach, and epithelial cells that secrete the gastric acid, and also intrinsic factor. What do you need intrinsic factor for? B12 absorption. Very good. Gastric chief cell or peptic cell. Remember, you also have chief cells in the parathyroid gland, right? That make parathyroid hormone. But gastric chief cell releases pepsinogen and renin, and this is renin in 2 ends and not 1. More confusion, but if it's 1 end, it's the renin-angiotensin pathway. If it's 2 ends, it's from the stomach. Usually it's our chief cell or zymogen cell. If you don't say it's from the parathyroid gland, you're talking about the stomach. It also secretes gastric lipase, which is going to digest lipids. Alpha cells in the pancreas, glucagon, going to be released when glucose levels drop, stimulates glycogenolysis in the liver. Beta cells in the pancreas are going to make insulin. This is released when you have insulin levels are high. Stimulates the uptake of glucose into body cells. Delta cells secrete somatostatin, which actually regulates both insulin and glucagon release. So it actually suppresses it. So the delta cells, the somatostatin seems to just sort of tamp down the activity of the pancreas. You also have gastrin G cells in the stomach and also in the enteroendocrine cells in the duodenum. And in the stomach, vagus nerve or any stimulation from the vagus nerve or food, or you have incomplete digested proteins. It's going to increase stomach motility, stimulate hydrochloric acid and other enzymes. Secretin, when the chyme enters the duodenum, it's going to increase secretion of the bile by the liver, increase secretion of bicarbonate by the pancreas. Why would you want that? Why do you need bicarbonate from the pancreas? Changes the pH very rapidly from a very, very acidic stomach to an alkaline pH in the duodenum. Your enzymes work in an alkaline environment in the duodenum. So you have to reverse that pH very quickly, and that's why the pancreatic juice is so high in bicarbonate. Okay? Also decreases gastric motility, another secretory rates. Gastric inhibitory peptide is what it sounds like. When you have fats and carbs, especially glucose, enter the small intestine, inhibits gastric activity, increases intestinal secretion, stimulates lipid synthesis in adipose, increases glucose use by skeletal muscle. Cholecystokinin, or CCK. This is produced when you have fatty chyme or partially digested proteins that enter the duodenum. This is going to cause, think about CCK, the easy way to remember this is, when you eat a fatty meal, how do you feel afterwards? Like you ate a brick, right? And for hours and hours, right? You don't want to eat anymore. You're like, you should have all those French fries. They just hang in. Why? Because it stops the motility of the stomach and will allow only a little bit of chyme to be squirted into the duodenum at a time. So you can so the release of CCK causes the gallbladder to contract. So you're getting bile into the duodenum, but it also slows down the motility of the stomach. And also causes the pyloric sphincter to close off. Relaxes the hepatos pancreatic sphincter or sphincter of Oddi, sphincter of Apula. Ejection of pancreatic juice causes contraction of the gallbladder as well, but slows the motility of the stomach. You have vasoactive intestinal peptide, VIP. You heard of any of these? I never heard of this before I did this board review. Vasoactive, what do you think it does? Dilates the capillaries in the duodenum. Inhibits hydrochloric acid production as well, increases absorption of nutrients. Ghrelin is produced by P or D1 cells in the stomach and epsilon cells in the pancreas, induces satiety and stimulates growth hormone. Renin-angiotensin pathway, how are we doing for time and energy? What time is it?
It's 2:47.
2:47. You want to take a break again? Or just keep going? Just keep going. Renin-angiotensin. Okay, so angiotensinogen is made by the liver and adipose. 20% adipose. I said that earlier. When it's released, it's just floating around in the blood. When the kidney senses that there is a drop in the pressure in the afferent arteriole, there are specialized smooth muscle cells in the walls of the afferent arteriole that are called juxtaglomerular cells. They will produce renin. What it's responding to is low blood pressure. Why do the kidneys care about blood pressure, Allison? Alyssa, sorry. Why do kidneys give a rat's ass about blood pressure? What can't they do if there's not enough pressure? Filter. They can't filter the blood, right? So if the blood pressure starts to drop in the afferent arteriole, the kidneys are like, wait a minute, what's going on here? We can't do our job. It releases renin. Renin is going to convert angiotensin to angiotensin 1. As it passes through the lungs are going to release an enzyme called ACE, angiotensin converting enzyme, and that's going to make it fully activated as angiotensin 2. There are several things that angiotensin 2 do to raise your blood pressure. It makes you more
Alert.
responsive to sympathetic activity. So sympathetic, what's going to happen to your blood pressure? You go up. So it's going to make it go up even more if you have sympathetic reaction. Okay. You're also going to cause the release of aldosterone from the adrenal gland. What layer in the adrenal gland produces aldosterone?
Glomerulosa.
Zona what?
Glomerulosa.
Glomerulosa, very good. Zona fasciculata is cortisol, and then zona reticularis is androgen. Very good.
Great. Fat, right?
How about the medulla?
How about the medulla?
What does it make? Epinephrine, 80% epinephrine, 20% norepinephrine. Right? What's unique about that tissue in the body? Definitely getting a good question. It's the only one that has a single neuron system in the sympathetic system. So it only has the preganglionic fiber. There is no postganglionic fiber. It just goes directly to the adrenal gland. It acts like a postganglionic sympathetic fiber.
Just medulla.
Just the medulla. It's the only tissue in the body that's like that. All right, so you have aldosterone secreted. Aldosterone is going to release, it's going to cause the reabsorption of sodium. Along with sodium, you drag water along with it in the distal convoluted tubule, that's the target tissue, and that's going to raise your blood pressure. It's also going to cause the release of ADH, where is ADH here for the posterior pituitary, again made in the supraoptic nuclei in the hypothalamus. That's going to cause the reabsorption of water in the collecting duct mainly. Because the reason why there are receptors in the distal convoluted tubule as well, but notice that it's 200 here, 200 here. It's not going to have a lot of reabsorption unless there's a big change and a big difference in the numbers. Okay, so it really works more in the collecting duct. And it's also going to cause vasoconstriction in high amounts. And the thing that's not here is it causes increased thirst as well. So you'll drink more. That's obviously going to put more water into the system and raise your blood pressure. Menstrual cycle. So we have the follicular phase and we have the luteal phase. At the day 14 or thereabouts, you have ovulation, which is the release of the egg. So you have this recruited follicle, it starts to enlarge and mature. That's due to estradiol. You also have a surge in luteinizing hormone towards the end, and follicle stimulating hormone as well. And then once it ruptures and releases the egg, this reorganizes and becomes the corpus luteum, which now produces progesterone. And that's what causes your progesterone levels to go up. Now, if there is no pregnancy, the corpus luteum degenerates, progesterone levels decline, and then you get sloughing off of the uterine lining. Question on that? Did you do this at all in any of the classes? You must have done this in embryology, right?
Path most recently.
And what?
Pathology too.
Oh, good. Okay. Calcium homeostasis. So we have two glands. We have the parathyroid and the thyroid. Now, a lot of this is confusing because they sound, a lot of the stuff sounds the same. Okay, so parathyroid gland is going to release when you have low calcium levels. You're going to release parathyroid hormone. Now, this says stimulates, what does it say? Stimulates osteoclasts more than osteoblasts. Doesn't stimulate osteoclasts at all. So that's wrong. Okay? What it does is stimulates osteoblastic rankle, which is going to stimulate osteoclasts to break that bone. Right? Also, it's going to have enhanced reabsorption of calcium in the kidney. You're also going to cause the formation of calcitriol, which is the 125 dihydroxycholecalciferol version of vitamin D, which is going to cause calcium binding protein to be formed in the gut, and you're going to absorb more calcium from your gut under the influence of vitamin D. Okay? And then obviously all that's going to cause blood calcium levels to go up, and then it's restored to normal. As your calcium levels go higher, you're going to release calcitonin, tone it down, from the C cells or clear cells or parafollicular cells of the thyroid gland. All the same cell. This cell here is the chief cell in the parathyroid. The calcitonin is going to cause increased excretion of calcium in the kidney. You're also going to make, it's going to cause more deposition of bone in calcium in the bone by inhibiting osteoclasts. And this is really only in pregnant women, we're not really sure what it does as far as that part of it. But what it's also gonna do is cause you to form the 24-25 version of vitamin D, and that's not the active form. Okay? And then blood calcium levels decline, and you have homeostasis. All right, so we have motor or descending pathways in red. Okay, we have the pyramidal tracts, the lateral corticospinal tract, and the anterior corticospinal tract. Where's the decussation? At the pyramids, right? And extrapyramidal tracts, rubro, recto, reticulo, olivo, and vestibulospinal. Remember, anything that ends in spinal is going to be a motor tract. Right? These are all extrapyramidal. The sensory, you have the dorsal columns, medial lemniscus, the cuneatus fasciculus is coming from the upper extremity. Gracilis is more medial, and that's coming from the lower extremity. This is going to be 7 things that are going through the dorsal columns, right? You have light touch, vibration, pressure, 2-point discrimination, graphesthesia, stereognosis, and you have this last one, conscious proprioception, right? And then you have the spinal cerebellar tracts, posterior, spinal cerebellar, and anterior. You also have a let's see. You have a third one, but it doesn't list it here. Anyway, these are going to cerebellum. And they're going to be giving you input about movement of the limbs, okay? Or movement in general, I should say. Anterior lateral is going to be lateral spinal thalamic, and the anterior spinal thalamic, this is going to be pain and temperature. Okay? If we look at the dorsal columns, it's going to come up on one side, decussate at the medial lemniscus, is going to decussate in the medulla, and then go up on the opposite side to the thalamus, and then from the thalamus to the sensory cortex. If you look at the spinal thalamic tract, it's going to cross at the level or 2 or 3 above. It can go up and down in the source, the tract of Lesueur, but it's only going to go up a few and then decussate. And then it's going to go all the way up to the thalamus, and then another, the third order is going to go up to the sensory cortex. All right, so for a reflex, you have the ability to end an organ. It's stretched here, it's going to cause contraction of the muscle, and then this is going to go all the way up to the cerebellum, and you're sensing the movement of the joint at the cerebellum. So when they say this is a simple reflex arc or monosynaptic, it's not really monosynaptic, but to make it happen is monosynaptic. You can cut this off here, and it's still going to happen as far as the, coming in here and then stimulating the lower motor neuron. Okay. So if you see a lesion of Bell's, like Bell's palsy, cranial nerve 7, you're going to see that the muscles of facial expression are going to be, you're going to have all 3 branches are going to be affected here, where if you have a stroke, you're actually going to preserve the upper part here, because that's duly innervated. Lateral corticospinal tract, it's coming down from the motor area. Here's your upper motor neuron, and it's going to decussate the pyramids, as we said before, and then come down. I think it's 80% decussate here. Is that what you learned? Yeah, and 20% don't decussate there, but let's just say it decussates at the pyramids, comes down, stimulates the lower motor neuron, that goes out to whatever it's supposed to happen. And then you have your anterior corticospinal tract, which is going to come down and looks like it decussates at the spinal cord level. All right, complement. So you have three pathways, classical, you have the alternative pathway or elected. And then, I'm sorry, or the appropriate pathway, and then you have the elected pathway. So both the classical pathway and elected pathway are gonna have the same C3 convertase. Okay, so what ticks off the classical pathway is IgG or IgM. Gets recognized by the antigen-antibody complex gets recognized by C1, and C1 is going to become an esterase that's going to cause C4 to break apart to C4A and C4B. C4B goes off to become stimulate anaphylaxis or mast cells. C2 is going to be broken apart to C2A and C2B. C2B is going to go off instead. So now you have C4A, C4A. This is wrong. This should be C4B. Oh, this is right. So you should have C4B, C2A. This is wrong. This should be C2A, right? So you gotta fix this. This is wrong. So C4B, C2A is C3 convertase on these pathways. Sorry about this. This is wrong. I didn't do this. And then C3B is going to join us to become the C5 convertase. That's going to go C5 to split. C5B, 6, 7, 8, 9 is the membrane attack complex, and then lysis to the cell. So from here on, from the C5 on, it's going to be the same pathway. The alternative pathway is C3 spontaneously cleaves, and then it binds to water, and factor D allows factor B to be acted on, splits B into BA and BB. So you have C3, this should say B, H2O, BB. And then that is going to be your new factor 3 convertase, and that's going to cause C3BBB, and then it's really two of these C3Bs, and then the BB, and that's going to cause that's going to be a new C5 convertase, and then it's going to be the same thing. So C5 is going to split, C5A and C5B, and they go down the same pathway. Any questions on that?
You said the two pathways converge to C5, not C3B.
Well, you're getting C3B, but it's a different. The difference is that this C5 convertase is different than this C5 convertase. And remember, this is not stable. This right here is not stable as propionic binds this, which it doesn't say here. So this spontaneous cleavage of C3 is a C3A and C3B. It just kind of falls apart. It's not stable unless propionic binds to it. Propionic binds to it, that allows D to bind to it, which allows B to be cleaved into B, A, and BB. I know, right? The nightmare continues, right? You thought you were over this. So the only classical pathway requires antibodies. Only the classical pathway requires antibodies, IgG or IgM. Constant region of the heavy chains was recognized by C1. Type 3 hypersensitivity reaction is due to immune complexes getting deposited in tissues, like the glomerulus, the skin, and the synovium, activates complement via IgG and IgM. So if the immune complex has IgG or IgM and it gets stuck in normal tissue, it's going to activate complement, and then you get damage from complement in normal tissue. So this is in, like, you'll see this in lupus, rheumatoid arthritis is another example of this. Hypersensitivity reactions. Now, type 1 is anaphylaxis. Or it's also called immediate hypersensitivity reaction. Involves IgE and mast cells. Now, it's a misnomer because the first time you're exposed, you don't have any symptoms. That's called your sensitizing dose. Then you have to be exposed again. That's your shocking dose, and that's when you get the massive degranulation of mast cells and the anaphylaxis. So the mast cells release histamine, heparin, chemotactic factors, make leukotrienes and prostaglandins from the fatty acids in the plasma membrane. Cardiovascular shock, what happens is your blood pressure goes way down because the mast cells cause the blood vessels to dilate and become leakier. The fluid leaks out of the cardiovascular system into your tissue spaces, and now your blood pressure drops precipitously. Dyspnea, tachycardia, sensitizing dose has to be followed by a shocking dose. So if you've been stung by a bee once in your life, you don't know if you're allergic to bees. You have to be stung twice. Okay? Type 2 sensitivity reaction. Now, both type 2 and type 3 involve IgG and IgM. But the difference is, type 2, you're actually making the IgG and IgM against a normal tissue, which then is going to activate complement and you get opsonization, inflammation, and lysis. Type 2 is your immune complexes get deposited in normal tissue. So instead of making an immunoglobulin towards a normal tissue, that's type 2. You're making an antibody to, let's say, strep. And then that gets deposited in your glomerulus, activates complement, and then you get what's called post-streptococcal glomerulonephritis. So you get glomerulonephritis because the strep antibody immune complexes get stuck and activate complement. Okay, does anyone not see the difference between the two? Because it's a little confusing. And then type 4 doesn't involve antibodies at all. This is called delayed onset hypersensitivity. This is T cell infiltration. This would be like poison ivy. Tissue rejection is also type 4. Okay? All right. That's what I have for you. I have a whole other thing that I sent you that you can go through ad nauseum with the senses, the special senses and everything. It's like, yeah. Whatever Grizzly detail you need there. What time we got?
307.
307? All right. Any questions? Any burning desires there? Yeah.
Yeah, real quick, the parts of the antibody, the F versus.
Oh, yeah, sure. So the FAB region is where the antigen binds. So if you look at antibody, it kind of looks like a pitchfork, right? You have two light chains, two heavy chains like this. This is the FAB region here. There's two binding spots on one molecule. And then this part here is the FC region, the constant region. So what makes this, let's say this is an IgG, this is a constant region. So there's only 5 versions of this, of the constant region. G, M, A, E, and D, right? But the FAB region is going to be hundreds of thousands of combinations because it has to be specific for a specific pathogen. Okay? Now, the only thing you can switch once you make an antibody, once you have a programmed plasma cell, the only thing that can change is the constant region, not the variable region. So you can switch classes of antibodies, but you can't switch which bug you're going after. Because remember, it's pre-programmed, right? You already have B lymphocytes in your body that are programmed for a specific bug, right? So that's programmed for that bug. It can only respond to that bug. But it can produce, once it becomes plasma cells, they can switch the class depending on if it's a parasitic infection or bacterial infection, whatever is best at killing off the pathogen. All right? Is that, any other questions? All right.